we're going to continue our discussion of the nervous system. We're going to skip over the brain. We'll come back to that next week. But this week we're going to look at the spinal cord, the nerves that come off the spinal cord, and some reflexes that they mediate. So the spinal cord is there to, and nerves, conduct sensory and motor information up and down the spinal cord. There is neural integration in the spinal cord. Some spinal neurons receive input from multiple sources, integrate it, and execute the appropriate output. Bladder control doesn't need to go all the way up to the brain to be figured out. The spinal cord is important for locomotion. That's where we have some central pattern generators, which are groups of neurons that coordinated repetitive sequences of contractions for walking. And we have reflexes that are based within the spinal cord, involuntary responses to stimuli that are vital to things like posture, coordination, and protection. The spinal cord itself is a cylinder of nervous tissue that arises from the brainstem at the foramen magnum of the skull, occupies the upper 2/3 of the vertebral canal. Its inferior margin is right around L1, averages about 1.8 centimeters thick and about 45 centimeters long. It does give rise to 31 pairs of nerves, which we call spinal nerves, and it has segmented. There are parts of the spinal cord supplied by each pair of spinal nerves. Spinal cord surface anatomy has a longitudinal grooves on the anterior and posterior sides. It's divided into the central, thoracic, lumbar, and sacral regions. Two areas of the cord are thicker than elsewhere. We call these the cervical and the lumbosacral enlargement. The cervical enlargement gives rise to the nerves of the upper limb, while the lumbosacral enlargement gives rise to the nerves of the pelvic region and lower limbs. There is a medullary cone at the inferior point of the cord, and at the very end we have bundles of nerve roots that occupy the vertebral canal from about L2 to S5, look like a horse's tail, and in fact they are named with the Latin for horse's tail, cauda equina. The meninges are fibrous membranes that enclose the brain and spinal cord. They separate the soft tissue of the central nervous system from the bones of the cranium and the vertebral canal. From superficial to deep, we have dura mater, arachnoid matter, and pia mater. That dura mater forms a loose-fitting sleeve around the spinal cord. It's tough, thick membranes composed of dense, irregular connective tissue. This is where we find epidural space, which is the space between the dura and the vertebral bones. It has blood vessels, adipose tissue, loose connective tissue, and it is a place where anesthetics can be introduced when you have an epidural procedure. The name dura mater actually means tough mother. Arachnoid matter is an arachnoid membrane adhering to the dura and separated from the pia by fibers spanning the subarachnoid space filled with cerebrospinal fluid. It's inferior to the medullary cone in the lumbar cistern. It's the location of a spinal tap or lumbar puncture to sample central nervous system. And it got its name arachnoid matter because it does have a spider web-like appearance, and in fact arachnoid matter means spider mother. Pia mater is the delicate transparent membrane that follows the contours of the spinal cord continuously inferiorly as the fibrous terminal filium. It fuses with dura to form the coccygeal ligament. It has denticulate ligaments, extensions of the pia that pass through the arachnoid to the dura, anchoring the cord in place. And pia mater means gentle mother. We have gray matter and white matter in the spinal cord. The gray matter is a duller in color because it has no myelin. Contains neurons, cell bodies, dendrites, and proximal portions of axons. White matter is a bright pearly white color because of the myelin. And those are axons that are bundled, coursing up and down the spinal cord. The gray matter has a central core shaped like a butterfly with two posterior horns, the dorsal horns, receiving sensory fibers, synapse with interneurons in the horn. The two anterior horns or ventral horns contain cell bodies of the motor neurons. There are lateral horns in segments T2 through L1. They are associated with the sympathetic nervous system. The left and right sides are connected by the gray commissure, and there is a central canal at the center of that commissure. White matter surrounds the gray matter. There are three large bundles of axons, posterior, lateral, and anterior funiculus on each side of the cord. Each funiculus is subdivided into fasciculi or tracts. This shows you the location you're trying for a lumbar puncture. Fibers in a given tract have a similar origin, destination, and function. So we have ascending tracts that carry sensory information upward, descending tracts that carry motor information downwards. We have decussations, which are crossings in the midline that occur in many tracts so that the brain senses and controls contralateral side of the body. Contralateral means when the origin or destination of a tract are opposite sides of the body, whereas ipsilateral is when the origin and destination of a tract are on the same side of the body, so there's no descutation. Ascending tracts carry sensory signals across three neurons from origin, the receptor, to the destinations in the sensory areas of the brain. The first order neuron detects the stimulus and transmits the signal to the spinal cord or brainstem. The second order neuron continues to the thalamus and the upper end of the brainstem, while the third order neuron carries the signal the rest of the way to the sensory region of the cerebral cortex. Posterior funiculus consists of cunicate fasciculus and gristle fasciculus. The gristle fasciculus carries signals from the mid-thoracic and lower parts of the body, while the cunate carries signals from the chest and upper limbs. Their first-order neurons travel up the ipsilateral side of the spinal cord, terminating at the medulla. The second order cross to the other side of the brain. It carries signals for vibration, visceral pain, deep and discriminative touch, proprioception from the lower limbs and lower trunk. And that proprioception is a non-visual sense of the position and movements of the bodies. The spinothalamic tract is part of the anterolateral system that passes up the anterior and lateral funiculi of the spinal cord, carrying signals for pain, pressure, temperature, light touch, tickle, and itch. Tract is composed of axons of second-order neurons. The first-order neurons end in the posterior horn of the spinal cord. Second-order neurons start in the posterior horn and then desiccate and form the spinothalamic tract. The third-order neurons continue from there to the cerebral cortex. Due to the cross of the second-order neurons, signals are sent to the cerebral hemisphere that is contralateral to the site of stimulus. The spino-reticular tract travels up the anterolateral system, carries pain signals resulting from tissue injury. It's composed of axons of second-order neurons. The first-order neurons enter the posterior horns and immediately synapse with second-order neurons. Second-order neurons desiccate to the opposite anterolateral system. They ascend the cord and end in the reticular formation, which is a loosely organized core of gray matter in the medulla and pons. The posterior and anterior spinocerebral tracts travel through the lateral funiculus, carrying proprioceptive signals from the limbs of the trunk up to the cerebellum. They Axons are second-order neurons. First-order neurons will originate in the muscles and tendons and end in the posterior horn of the spinal cord, while the second-order neurons ascend the spinocerebral tracts and end in the cerebellum, and the cerebellum is using it for feedback to coordinate movements. The descending tracts involve two motor neurons, an upper motor neuron and a lower motor neuron. The upper motor neuron originates in the cerebral cortex or the brainstem and terminates on a lower motor neuron. That lower motor neuron cell body is within the brainstem or spinal cord, and the axon leads to the muscle or the whatever target organ it is supposed to. There are lateral and anterior corticospinal tracts carrying signals from the cerebral cortex for precise, finely coordinated movements. Pyramids are ridges on the anterior surface of the medulla oblongata formed from fibers of the system. Most fibers desiccate in the lower medulla, forming a lateral and corticospinal tract on the contralateral side of the spinal cord. Some fibers form the anterior or ventral corticospinal tract and descend in the ipsilateral side of the spinal cord, desiccating inferiorly. They, like the lateral tract, they ultimately control contralateral muscles. Other descending tracts include the tectospinal tract, which begins in the roof of the midbrain, the tectum, and descends to the contralateral spinal cord as far as the neck. It functions in reflex turning of the head in response to sight or sounds. The lateral and medial reticulospinal tracts originate in the reticular formation of the brainstem. They control muscles of upper and lower limbs, especially those of posture and balance. They contain the descending analgesic pathways that regulate transmission of pain signals to the brain. We have the lateral and medial vestibulospinal tracts, which begin in the brainstem, the vestibular nuclei. They receive impulses for balance from the inner ear and control extensor muscles of the limbs for balance. Poliomyelitis, polio, and amyotrophic lateral sclerosis, ALS, are caused by the destruction of motor neurons that lead to skeletal muscle atrophy from lack of innervation. Polio is caused by the poliovirus. It destroys motor neurons in the brainstem, the anterior horn of the spinal cord. Signs of polio include muscle pain, weakness, loss of some reflexes. It can be followed by paralysis, muscular atrophy, and respiratory arrest. The virus spreads by fecal contamination of water. ALS, commonly referred to as Lou Gehrig's disease, results from the destruction of motor neurons and then muscular atrophy. Also sclerosing or scarring of the lateral regions of the spinal cord. Astrocytes fail to reabsorb the neurotransmitter glutamate from the tissue fluid, which accumulates to toxic levels. Early signs of ALS include muscular weakness, difficulty speaking, swallowing, and using hands. Sensory and intellectual functions remain unaffected. The spinal cord communicates with the rest of the body by way of spinal nerves. A nerve is a cord-like organ composed of numerous nerve fibers, axons, bound together by connective tissue. Contain anywhere from a few nerve fibers to a million. The smaller branches are called peripheral nerves. Disorders of those nerves would be known as peripheral neuropathy. Wrappings associated with a nerve, connective tissue wrappings, a endoneurium is a loose connective tissue external to the neural lemma. Then those are grouped in fascicles by perineurium, and the entire nerve is surrounded by epineurium. It should be very familiar to you, very similar to the structure we had with muscles, except it was endomysium, paramysium, and epimysium. Blood vessels do penetrate the connective tissue coverings and provide a plentiful blood supply to the nerves. Nerves are classified as either sensory, motor, or mixed. Sensory nerves, composed only of afferent fibers, carry signals from sensory receptors to the central nervous system. They are relatively rare. There are some we'll see in the cranial nerves for smell and vision. Most are going to be mixed nerves. Motor nerves, composed only of efferent fibers, they carry signals from the central nervous system to muscles and glands. And then the most common type, again, is the mixed nerves that have both afferent and efferent fibers in them. Based on the organs they innervate, sensory and motor fibers can also be described as either somatic or visceral, general or special. Clusters of nerve cell bodies outside the central nervous system are known as ganglia. They are enveloped in an epineurium continuous with the nerve. Among the cell bodies are bundles of nerve fibers leading into and out of the ganglion. The posterior root ganglion is associated with spinal nerves. There are 31 pairs of spinal nerves, 8 cervical, C1 through C8. First cervical nerve exits between the skull and the atlas, the other exit at the intervertebral foramina. There are 12 thoracic, T1 through T12, 5 lumbar, L1 through L5, 5 sacral, and 1 coccygeal. Each spinal nerve is formed by 2 roots, the proximal branches. The posterior or dorsal root is sensory input to the spinal cord. Posterior root ganglion contains the neurosomas of the sensory neurons carrying signals to the spinal cord. Has 6 to 8 rootlets that enter the posterior horn of the cord. The anterior or ventral root is the motor output side of the spinal cord. And there are 6 to 8 rootlets that leave the spinal cord and converge to form the anterior root. And then this structure is formed into the cauda equina from roots L2 to coccygeal 1. The distal branches beyond the vertebrae, the nerve's going to divide into the anterior ramus, posterior ramus, and meningeal branch. The anterior ramus in the thoracic region gives rise to the intercostal nerves. In other regions, the anterior rami form nerve plexes. Posterior ramus innervates the muscles and joints in that region of the spine and skin of the back. And the meningeal branch re-enters the vertebral canal and innervates the meninges, the vertebrae, and the spinal ligaments. Chickenpox, varicella infection, is a common disease of early childhood caused by varicella zoster virus, produces an itchy rash that clears up generally without complication, not always. Chickenpox can be a very life-threatening disease. But the virus will remain for life in the posterior root ganglia. It's kept in check by the immune system. However, once in a while, shingles, herpes zoster, is a localized disease caused by the virus traveling down the sensory nerves by fast axonal transport when the immune system becomes compromised. That leaves a painful trail of skin discoloration and fluid-filled vesicles along the path of the nerve, usually on the chest and waist on one side of the body, and pain along with itching. This tends to be much more common after 50. Chickenpox vaccinations reduce the risk of shingles later in life, and we do have immunizations for shingles specifically as you reach the age of 50. Anterior rami branch and anastomose repeatedly, forming 5 nerve plexuses. The cervical, brachial, lumbar, sacral, and coccygeal. In the neck, the cervical plexus, C1 to C5, supplies neck and phrenic nerves to the diaphragm. The brachial plexus near the shoulder, C5 to T1, supplies the upper limb and some of the shoulder and neck, divides into roots, trunks, divisions, and cords. The lumbar plexus in the lower back, L1 through L4, supplies the abdominal wall, anterior thigh, and genitalia. The sacral plexus in the pelvis, L5, L4, S1, and S2, S4, supplies the remainder of the lower trunk and lower limb, including the sciatic nerve. They have sensory and motor functions. The somatosensory function carries sensory signals from bones, joints, muscles, and skin, things like touch, heat, cold, stretch, pressure, and pain, and they provide proprioception, receiving information about body position so that the cerebellum can know where we are in three-dimensional space and make a plan to get us where we want to be. The motor function is primarily to stimulate muscle contractions. Radial nerve injury. The nerve passes through the axilla, may be compressed by crutches, called crutch paralysis, leading to wrist drop. The fingers, hand, wrist chronically flexed because the extensor muscles are paralyzed and can't move, can't oppose the flexors. Sciatic nerve injury. Sciatica is a sharp pain that travels from the gluteal region along the posterior side of the thigh to the leg and ankle. About 90% of the cases are caused by herniated intervertebral disc or osteoarthritis of the lower spine. A dermatome is a specific area of the skin that conveys sensory information to a spinal nerve. So we have dermatome maps, a diagram of the cutaneous regions innervated by each spinal nerve. Dermatomes can overlap their edges by as much as 50%. It's necessary to anesthetize 3 successive spinal nerves to produce a total loss of sensation in one dermatome. And here is one of the dermatome maps, the front of the body. Reflexes are quick, involuntary, stereotype reactions of glands or muscles to stimulation. A reflex requires stimulation. They're not spontaneous actions. They are responses to sensory inputs. They are quick. They involve few, if any, interneurons in a minimum synaptic delay. They are involuntary. They occur without intent, without conscious thought, and they are difficult to suppress. And they are stereotype, which means they essentially occur the same way every time. Reflexes include glandular secretion and contraction of all 3 types of muscles. We have somatic reflexes, those involving the somatic nervous system innervating skeletal muscle, and visceral reflexes, those involving organs such as the heart and the intestines. Somatic reflex involves a reflex arc, and that follows a pathway. Somatic receptors in the skin, muscles, or tendon give information to afferent nerve fibers carrying the information from the receptors to the posterior horn of the spinal cord or the brainstem. There's an integrating center, a point of synaptic contact between the neurons and the gray matter of the cord or brainstem, which determines whether the efferent neurons should issue a signal to the muscles. The efferent nerve fibers would carry that motor impulse to the muscles, and the effectors are the muscles themselves that carry out the response. When we strike the patella tendon, information goes to the spinal cord. It passes along through another nerve, sends a signal back to contract this muscle and also to relax this muscle, and causes the response of the foot to rise. Many somatic reflexes involve muscle spindles, which are stretch receptors embedded in the skeletal muscle. They serve as proprioceptors, organs that sense the position and movement of the body. They inform the brain of the muscle's length and body movement. They enable the brain to send motor commands back to the muscle to control coordinated movement, corrective reflexes, muscle tone, and posture. The structure of a muscle spindle includes intrafusal fibers, which are modified muscle fibers within the spindle. The rest of the muscle fibers, those generating the force for movement, are extrafusal fibers. There's a gamma motor neuron innervating the ends of an intrafusal fiber and keep it taut. The alpha motor neurons supply the extrafusal fibers. Midpoint of the interfusal fiber contains sensory nerve fibers. Primary afferent fibers are motor fibers. The length and determine changes in length and speed, while the secondary afferent fibers monitor length only. So if you help you keep you upright when you're standing on a boat, as that boat is moving beneath you, or a skateboard or some other thing that's difficult to balance, it is reflexes involving these spindle apparatus that help you do that. A stretch reflex is when a muscle is stretched, it fights back and contracts. That helps us to maintain equilibrium posture. Head starts to tip forward as you fall asleep. Muscles contract and raise your head. Stabilizes joints by balancing tension and extensors and flexors and smoothing out muscle actions. Stretch reflex is primarily mediated by the brain, but its spinal component can be more pronounced if a muscle is suddenly stretched by a tendon tap, so the knee-jerk reflex. A monosynaptic reflex arc, one synapse between the afferent and the efferent neurons. There's a little synaptic delay, very prompt response. So that patella, the knee-jerk reaction, is a monosynaptic reflex. Testing somatic reflexes helps diagnose many diseases because they are simple neuronal circuits without a lot of redundancy. So if there's problems in the nervous system, these simple reflexes probably will show it sooner than more complex responses. There is reciprocal inhibition, a reflex phenomenon that prevents muscles from working against each other by inhibiting the antagonist while the agonist is excited. The flexor reflex is the quick contraction of a flexor muscle, results from withdrawal of a limb from an injurious stimuli, triggers contraction of the flexors and relaxation of the extensors in the limb. This is a polysynaptic reflex arc, so it's a pathway in which signals travel over many synapses on their way to the muscle. Crossed extension reflex, we get contraction of extensor muscles in the limb opposite of the one that is being withdrawn. It helps maintain balance by extending the other leg. Flexor reflexes use an ipsilateral reflex arc, stimulus and response on the same side, where the crossed extension reflex uses a contralateral reflex arc. The input and output are on opposite sides. This is an intersegmental reflex, one in which the input and output occur at different levels, segments of the spinal cord. Pain in the foot will cause contraction of abdominal muscles. Tendon organs are proprioceptors in a tendon near its junction with a muscle. They are involved in tendon reflex. It's about 0.5 millimeters long, consists of an encapsulated bundle of collagen fibers and one or more nerve fibers. A tendon reflex is a response to excessive tension on a tendon. It's going to inhibit the muscle from contracting strongly. It moderates muscle contraction before it tears the tendon or pulls it loose from the muscle or bone. Tendon organs. Spinal cord trauma, you can get a complete transection, complete severance of the cord. That will lead to the immediate loss of motor control below the level of injury. Above C4, that would pose a threat of respiratory failure. Spinal shock, paralysis has three forms: paraplegia, quadriplegia, and hemiplegia. Paraplegia is both lower limbs, quadriplegia is all four limbs, and hemiplegia is paralysis on just one side of the body. Paresis is a partial paralysis or weakness of the limb. And that concludes our look at the spinal cord. Next week, the brain.